pull the uh, forward to the microscope, the eye, what type of anesthesia you use?
Topical, just topical anesthesia.
Patient no
Uh,
doesn't feel anything.
no, there's minimal. No, I mean, it's topical anesthesia. We're not really pushing the eye around. We're just placing it on the cornea, and we basically move the head around. We don't move the eye with our hands because you cannot, right? You just can only hold the lens there, use the incision with an instrument, tilt the head a bit. I pretty well do 100% topical.
Your patients very good patients because our patients is always moves fast and
We
no
just we
top.
we just we just we just slap them like this, slap it. No, we don't. No, I mean, I think it depends on your patient profile. I mean, you can block them if you want, but that's not going to change their head. If they're doing this, then that's not going to help them, right? And if they're moving the eye everywhere, I generally find if I talk to the patients, and honestly, a lot of the factor is how you talk to the patients. I meet them beforehand. I say, hey, listen, I'm going to be telling you what to do. I'm going to ask you to look here. If you have any questions, do that. Keep both eyes open. Look at the light. Look on the side. I control their head. I talk to them gently, and it usually works. Now, I don't have that many patients from Azerbaijan in Toronto, so maybe that's Azerbaijan is very difficult people. Are you difficult people?
Not at all.
One question more about the anesthesia regarding the blood pressure.
Yeah.
So, what the your maximal blood pressure should be in time this goniotomy?
Yeah, I mean, I don't like high blood pressure for many reasons. I don't think it's good. There's a risk in doing this, and particularly in these cases, yes, I think that there's risks here with bleeding and blood reflux and everything else. I mean, we try to keep the systolic pressure like below 180. Keep the diastolic pressure below 110, but we cannot always have that, right? These are always going to be patients who have cardiovascular disease. They can't always have that control. But I am fortunate. I usually have anesthesia with me, and they will give typically some midazolam, some fentanyl, make the patient relaxed. They make me relaxed. I'm so chill.
And also, you stop the uh, anticoagulants before the how
So
many?
this is an interesting question. I used to. I don't do as much now because remember one thing. The blood is not from cutting a vessel and getting bleeding. This is reflux bleeding, reflux blood coming from in the veins back into the eye. You push it back in with viscoelastic or with pressurizing the eye. So anticoagulants, they shouldn't affect the reflux because reflux happens because of pressure gradient. Now they can affect clotting, yes. So clotting is one factor. So you could argue that clotting would be less inhibited. But the reality is, when we do mixed procedures, the way we stop bleeding is by injecting viscoelastic and pressurizing the eye. So to me, I don't think there's a big issue with anticoagulants. I'm not very aggressive by stopping them, to be honest.
We have another question, and Dr. Jamil, have you finished with your questions? Sorry.
Yes.
Yeah.
Yeah, and I think that I see other people here too, so I want to give everyone a chance. Don't feel intimidated by the experts that are here. So
Yeah.
if you have any questions, I see that some of
Yeah.
you have been some of you have been paying attention really, really well. Really nice.
Yes, we have a question in here by Dr. Mehmet Fatih. How about your post-operative drug application when you prefer to stop steroids?
So yeah, so a couple of things. Glaucoma drops. Well, either I stop them after surgery or I reduce it or I continue them, depending on the severity. So someone who has advanced disease, high pressure before surgery, I will continue medications for the first, 2, 3 weeks, because these patients can get pressure spike or they can get a pressure elevation. I don't want that to happen. On the other hand, mild glaucoma, one medication, pressure is 20 before surgery. I'll stop it. I don't think they need it. But usually I will continue the medication, maybe even 1 or 2 drops for the first month, and then I will stop it. Because one mechanism of pressure elevation is steroid response. These patients still seem to get steroid response. And so it's helpful to have the medications on board because patients get unhappy. They post-op day 1 pressures 15, post-op week 1, the pressure is 30. It's possible steroid response, or maybe it's blood. But the point is that medications will help to reduce that risk. Steroids, yes, I use them early on. I use it 4 times a day for the first week, but then I want to get them off of it because steroids, again, can cause steroid response, but we don't need it as much. If there's no bleeding, for example, there's not really a big role for inflammation. If there's bleeding, then yes, I understand. We keep them on some drops because of the inflammation that's occurring. But I like to get them off it if there's not much bleeding. That's my preference.
We have another question from Professor Rasim Hajiev from Azerbaijan. In your opinion, does normalizing intraocular pressure through surgery in advanced stage 3 glaucoma stop the deterioration of vision or not?
Well, with very severe glaucoma, right? The question is very severe glaucoma, Lala?
Yeah, stage 3 glaucoma. Yeah. Advanced stage 3 glaucoma.
I don't know what stage 3 is. I don't use stages, but you mean like
It's a severe one, yeah.
How many stages are there? 3 or 4 or 5? How many
Dr.
stages?
Jamal?
If the MIGS classification, it's from 0 to 5.
Oh, well, stage 3 is not severe then, I guess. I usually use the Hodap Anderson Paris criteria, but let's suppose you have mean deviation worse than -12. You have visual field at the fixation. For me, this patient, MIGS is not enough, in my opinion. I think long term, the pressure needs to be 10 or 12. So I prefer to go to a bleb. Now, if the patient's pressure is 30, you could argue, well, do MIGS. Pressure comes down to 15. This is better. But the problem is, number one, those patients are at risk of pressure spike. Patients with advanced disease have more problems with the outflow beyond the canal. And long term, the patients are less likely to keep pressures below 12. They're going to be 15, 16. They probably have to be on medication still. They're fluctuating up and down. So I prefer to do confidently, I'll do a PreserFlow or a trap to get the best pressure control. That's what I do in my hands. So MIGS is not the answer for everything for me. For sure it isn't.
And he has also, Professor has the comments for that with their own new heart medicine treatment system, we can halt this process even with normal intraocular pressure. Optic nerve atrophy is an inflammation. It's a disruption of the balance between ocular microbiota, the surrounding antibodies. By restoring this balance, we improve visual acuity and the visual field. This is his opinion. How do you think?
Yeah, I mean, I think we have to look at this holistically. IOP is one factor. We know IOP is a risk factor. We know treating IOP can reduce the risk. That's for sure. But there are a lot of different theories, vascular, immunological theories, inflammatory theories, all these different theories we need to think about. And I would say that glaucoma is not one disease, heterogeneous diseases. And I think that nutrition, I think antioxidant approaches these are all very important ways to manage glaucoma. So I think that they should be all looked at. The challenge is, how do you prove it works, right? How do you prove it works? Because I can say anything works. I mean, this water bottle works, right? Drinking water, right? I don't know, right? So we have to have good biological and good evidence, but also have some good clinical evidence. And that's where it's a bit difficult, because the studies are not easy to do with neuroprotection, for example, and other factors. But I believe in those things, though. I believe in those things.
Thank you.
Including perfusion, right?
Yes. Any more questions?
Yeah, some of you have been watching very closely. Don't be shy. I want to hear a question from someone who's shy here.
Sorularınızı verin. Kimin soru varsa buyurun. Utanmayın. Question?
Oh, what does that mean? That means something bad?
I'm saying the same thing in Azeri.
Oh. Yeah, Azeri.
Yeah.
What do you speak? Azeri is called Azeri?
Yeah.
Oh, I like that language. Azeri.
Yes.
I have to learn this language before I come to Baku. Remember, April 6th to 13th. I got Baku.
Yes.
So I want you to send me a message so I can meet people and give me some advice. We'll have where to go.
We'll do something with that.
Anybody free that week? You can give me a tour. Like I want to.
Yes. With great
experience.
We'll do that.
Not the tourism. I want to experience the real Azerbaijan, right?
Yeah, we'll take you.
I think that's important. But listen, anybody who's shy here, come on. Narana, you've been listening. I want to ask Narana. I don't know who Narana is, but I see her listening.
Narana.
Come on, say something.
Nurana, say something. She's shying.
Shy?
Yeah, I think so.
What about Aigun? I know Aigun, she's always busy.
Yeah, Dr.
I
Aigun.
always I always see her at the meetings. She's always somehow
Dr.
we always see
Aigun,
each
please
other,
say
even for
something.
1 minute. Any it can be any question about anything.
Uh, I have a question.
Jamil, you're hogging all the time.
You know, the complication of the trap, the most devastating complication is the regarding the using MMC
Mhm.
uh, after a long time in conjunctiva. There happens some complications. So when you show us the Xen implant, during implantation Xen implant, we also
Yeah.
use vitamin C, MMC.
Yes. Yes.
So what is it the micro-invasive glaucoma surgery? We can
No,
this
I actually don't like to call Zen MIGS because it's a different type of procedure. It's a bleb procedure. There's a different series of complications and effectiveness, you know. So I have been calling this MIBS. It's bleb surgery, microinvasive bleb surgery. I do believe that complications happen not just from mitomycin C, but from the procedure. If the procedure is safer, the mitomycin is safer. If the procedure is more risky, the mitomycin is more risky. But all these procedures, whenever you do a bleb, there's always going to be a risk for infection, for hypotony, for bleb breakdown, erosion. That's going to be with any bleb procedure. The question is, how do we contain it? How do we reduce the risk? You know, that's where the differences between the different procedures. So I like Zen and Preserfly. I believe that it's safer. I believe the recovery is better, and the blebs are more posterior. They're more posterior from the limbus. So I think there's a benefit to that. But is it MIGS? No, it's not the same as putting a stent in the canal, right? There's a whole different procedure. That's so. Listen, 15 years ago we called everything MIGS, but now I hope people are differentiating MIGS and MIBS as an example. You know.
okay. After sometimes if mix does not work, you start again medicine or you going to trap or tube
Yeah,
surgery?
great question. Same thing with SLT laser. SLT doesn't work. What do you do next? I think medications have a role still, but I look at them as using them as bridges to the next intervention. So I will use it because I think it's going to be a lot to rush to do more surgery. And, you know, it gives us some time to, you know, to check it. I think doing trabeculectomy first line or doing it early, again, it's a different risk here, right? Now we're exposing a patient. We don't know whether the patient is going to get worse, how advanced they are. So the risk benefit ratio changes. You know, MIGS, the risk benefit's a bit better on less risk. But when we do a bleb, the risk is much greater. So I'm more cautious in doing surgery on those patients. I want to see the patient's getting worse. I want to see the patient has advanced glaucoma if we're going to do something more advanced. So that's what I'll do. Now, if someone I had a patient the other day. I did mild glaucoma. Pressure was 35 on 3 medications. I did MIGS. I did a eye track with goniotomy 3 years ago. Pressure was good. Now they come back. The disease is still mild to moderate, but the pressure now is 25 on 3 medications. What am I going to do now? I cannot do another MIGS. I don't like to do cycloablation. So I go to do a bleb surgery, but I'm going to do a Zen, for example, or Preserflow in that example. So, you know, those are the situations where I would do a bleb procedure after MIGS in that example.
There's one question from the resident ophthalmologist, second year.
Oh no, we don't take no resident questions, but they're losers. They're losers. I'm just kidding. I love residents.
Yes,
You guys know that.
Turkan,
Residents are the
Turkan,
best
would you
because they're
like to
learning and
ask,
excited. I love it.
Dr. Turkan, would you like to ask by yourself?
Yes, Dr. Turkan. Let's see,
Do
where's
you
Dr. Turkan?
know? Okay, she's asking that.
No, where's Dr. Turkan? Let me see. Where's
Turkan,
Turkan?
open your microphone, say hello.
Okay, hello.
She cannot.
We need to support our young people, our juniors. They're the future. They need to be comfortable. Don't feel shy with, at least don't feel shy with me, even if I'm professor and chair and I'm super the best guy ever. Doesn't matter, right?
Hi, Dr. Ahmed. Thank you very. Great speech.
Thank you.
Would you like to ask by yourself or? Yes, she's asking about the vitrectomized with silicone oil eyes. Have you performed the surgery in that eyes?
Ooh, those eyes are pretty diseased, you know, and so I typically, depending on the visual prognosis is poor, then honestly, sometimes I will do cycloablation, like cyclodiode.